Thank you, sir, for the kind introduction, and thank you to Dr. Akash Singh and the organizers of Diabetica. I'm primarily from Baroda, so it's always a pleasure to come back to Baroda for a talk. So this is home. I want to start with something controversial, right? What I'm going to say is, we have been treating the wrong disease. We are in the wrong conference, right? Trust me, 2025, this is the current year, 2035, there is not going to be a diabetica. Either you call it a metabolica or you call it a adiposity or whatever, you want to say. And I think at some point, and now there are some bigwigs of RSSDI here, the name of RSSDI should change to RSSDA or RSSDOI, because the disease we have been treating, we have all been treating the wrong disease. The disease is not diabetes. The disease is adiposity. The disease is adiposity, right? Diabetes is just one consequence of adiposity, just like chronic kidney disease is one consequence of adiposity. Cardiac involvement is one consequence of adiposity. The combining disease, the actual disease is adiposity. And don't take my word for it. Don't take my word for it. Just go outside. This is an industry-sponsored symposium, but the industries are outside, right? Once you take a walk in the industries and the pharma companies, tell me how many of them are actually promoting SUs even today? Very few. Tell me how many of them are actually promoting either a DPP4, a GLP, or an SGLT2? Almost all of them, right? How many talks did we have in this conference with SU1, which was Dr. Panikar's talk, where he talked about why you probably should not be using SU? How many of them you had about SGLT2? Quite a few. How many GLP? Well, you're going to see, I have a series of them. And interestingly, we had 2 talks on glitazones, which are one more than SUs. So I think the point is, we are treating the wrong disease, right? We are chasing the wrong target. Probably in future, when you have better markers of measuring adiposity at an organ-specific level, you will abandon the glucometers also. Trust me, right? The things are going to change. And like I said, controversial, but I have been proven right a long time, because almost a decade back, we actually wrote a scathing letter to editor criticizing the SU guideline, saying that why are we still talking about sulfonylureas when things are changing? Well, I was right, because now you had people talking relevant talks about SU. Okay, so this is the disease. This is the problem. Okay, how does all these diseases get combined, and what is the unifying common underlying hypothesis for the diseases that we are facing today? It's fat. Okay, and fat in locations where it should not be present. That's the major problem. You have fat in the epicardial region leading to myocardial infarction. You have HFpEF, right? You have fat in the pancreas, which you now know from Dr. Roy Taylor's work, which leads to beta cell dysfunction. You have fat in the liver. They're not shown liver here. Very interesting. You have fat in the liver, which leads to NFLD or MSLD or whatever name you want to give it, and leads to central insulin resistance. And then, of course, everything else combined in the same way. Very interestingly, and follow this work here also, there is now emerging evidence that there is fat in the renal sinus. There is a renal sinus fat, which is contributing to chronic kidney disease. You all heard, when I was doing my medicine residency, we had heard about obesity-associated glomerulosclerosis. That disease now, that name is coming back again. Right? And now people are realizing that even in type 2 diabetes, the CKD is probably because of renal sinus fat. And when you're giving SGLT2, apart from the vascular mechanisms which it has, it probably reverses the renal sinus fat also. And that is why it leads to improvement of the renal outcome. So things are changing, right? And things are changing for good, which is great, which is a good thing. Now, how does this all really start? What basically happens is, we are all, and this combining, the work done by, a lot of people from the fetal medicine space itself, right? So you had, Dr. Yajnik's work. And if you follow his work and you follow his philosophy, one of the things he says is that we are all, as Indians and, as South Asians, we are born with a problem. we are born with a handicap. We are born with less adipocytes and less capacity of adipocytes to carry the fat. That's the major problem. So you have X number of adipocytes which you are born with. You can increase that number by a small extent by some amount of, by hyperplasia and a little bit of increase in, numbers of the fat cells. But the problem is that there is still a limitation. We are limited with the number of fat cells we have. Now what we are doing is we are stuffing these fat cells with more fat. There comes a point where these fat cells cannot take fat anymore. When they can't take this fat anymore, it starts spilling out as free fatty acids, right? And this free fatty acid is a toxic molecule. That starts getting taken up by a lot of the organs. The first organ which starts taking up this free fatty acid is the liver, right? So you start having liver fat, and then eventually you have the pancreatic fat, and that is the point where you start developing, hyperglycemia. And then you have the epicardial fat, you have the perivascular fat leading to endothelial dysfunction, and all of them ultimately leading to the consequence, which now people call it as a CKM syndrome, that is, the kidney, the cardiac kidney, and the metabolism, right? Ultimately, it's all adiposity. It's all fat, which is the problem, right? Not usual fat, not your subcutaneous fat, right? But the fat in organs where this fat should not be. That's the major disease and that's the major problem, right? So, this is the puzzle, okay? So, you have the metabolic dysfunction, which is amplified by, other organ dysfunction. What happens is that this fat in itself is fine, but the problem is this fat starts burning. There is a chronic inflammation that sets in, and this chronic inflammation leads to more damage. And very interestingly, and this is again a theory which I've been having for a long time, the problem is when you have chronic inflammation, the body tries to heal. Now, in a normal person, this healing should be fine. But when you have a diabetic person, this healing happens with fibrosis. There's more of healing by fibrosis, and this healing by fibrosis leads to permanent organ damage. Case in point, every organ is showing the same problem. Case in point, you take your liver. You have fatty liver, and how does it heal? With cirrhosis, with fibrosis. You have the kidney, where you have the renal sinus fat. How does it heal? By causing glomerulosclerosis, again fibrosis. In the cardiac region, your epicardial fat, how does it heal? By producing fibrosis leading to your vascular involvement, right? And your cardiac walls starting to fail. A classic example is your frozen shoulder, right? The patients with diabetes coming with frozen shoulder. It's actually the classical example of fibrosis. Your recurrent trauma, and that trauma doesn't get healed and starts healing with fibrosis, and you have frozen shoulder. So the point is that we are all dealing with the same problem in different organs. The problem solution is actually this is the solution. The solution is actually to reduce the fat. So reducing adiposity should lead to a potential solution in all of these things, right? So how do you reduce adiposity? Now there are a couple of things you can do. First is reduce the fat itself. This is done by two drugs, only two drugs, GLP-1RA and SGLT2 inhibitors. So these are primary drugs for diabetes management. Metformin, sulfonylureas, they are not primary drugs for diabetes management. I'm sorry, right? Insulin, type 1, it is a primary drug. Type 2, it's a rescue medication. Your primary drugs are your SGLT2 and GLP-1. Start with that. Next step is, if you are not able to reduce the fat to a level, there is inflammation. And that inflammation has to be reduced. And very interestingly, a drug which actually reduces inflammation, which has long been misunderstood, is your statins, right? Statins are the drugs which lead to chronic reduction of inflammation. Now, you have cardiologists looking at colchicine, looking at anti-inflammatory drugs for cardiac risk reduction. Why? You want to reduce the chronic inflammation, right? And then you have beta cell dysfunction, and the beta cell dysfunction has to be tackled with your classical drugs like your sulfonylureas and insulin. But the pathway is this. Now, one unique thing you can do is use glucagon, which actually increases the number of fat cells, which is a very unique mechanism which no other drug does, right? But I still believe that in today's world, glucagon has more relevance to diabetes management than sulfonylureas, because you are again targeting a pathophysiology, which is a problem. But the drug which is now going to take a lot of our space and a lot of our space in conferences also is GLP-1RA, because that's a drug which is, I think, in a sense, come up with a new way of reducing the fat. How how does GLP-1 reduce fat? It does it through targets at different organs. So at the central level, starting from the top, at the central level, you have reduction of appetite. Then if you go down, right, at the GI level, it slows down the gastric emptying, reduces the fat, burns out the fat which is there, right, and produces a little bit of nausea and other symptoms, which leads to the patient taking less amount of food. So there is a distinct way in which the GLP-1 at a multi-level reduces the fat. It not only reduces the the fat absorption in the body's that mechanism, but it also acts at a central level by reducing the appetite, which is a very interesting thing, which now it is being discovered and more things are being understood. So what happens as a result of that? So you have a GLP-1 right? It reduces the appetite at the brain level. At the cardiac level, because of its improvement on the fat and the inflammation, it produces cardiac protection. At the liver also, it has all the benefits, pancreas and kidney, right? So what is the evidence of this, right? We'll skip some of the slides because some of these slides are old. Let's go to the slide which is actually relevant to this, and that is the SOUL trial. Okay, so the thing with GLP-1 RA is that you had plenty of GLP-1 RA through the year, right? So you had the oldest generation one, like your, liraglutide now should be considered older generation. Liraglutide, which showed remarkable cardiac benefit, right? It showed other benefits which were not seen with earlier class of drug. And then you had things evolve. You had dulaglutide, and then you had the oral semaglutide, right? Which is available in India. Now, the problem with oral semaglutide is that for the longest time ever, oral semaglutide, though showed all the benefits which you expected from a GLP, the catch was that it did not have a cardiac benefit arm, right? Which was one of the hindrances for oral semaglutide being widely adopted at a cardiac level as well. You had every other benefits being shown. You had a good HbA1c reduction, you had weight reduction, but the cardiac benefit was still lacking. And that is where the role of the new trial, which was just published. This was the old trial. This was the Pioneer 6 trial, which had shown some early benefits but did not show statistical significance. What really changed now is the SOUL trial. Okay, this is the one, right? So now the thing about SOUL trial is that it's just been published, right? So it's a very fresh off the oven kind of thing. This is the inclusion criteria. So they took patients with very similar to what you had in terms of other clinical trials. It was a very straightforward done. They looked at the standard, cardiac risk markers, that is the MI, stroke, and hospitalization for angina pectoris. Look, just be aware, they are not looking at the heart failure aspects, right? Remember, when you are dealing with an SGLT2, you want more of heart failure patients. But when you are dealing with a GLP, you want more of your atherosclerosis patients. And look at their inclusion criteria. Very smartly done. They looked at patients and their outcomes also. They're looking at patients with more of atherosclerosis or prevention of atherosclerosis rather than just looking at, a heart failure type of patients, which if they've done an SGLT2 trial, that is what they would have looked at. So they look at these outcomes. So this is the demographics of the patient. Again, majority of the patient were males, as you can expect. Mean age was 60, mean HbA1c was 8, BMI was 31. So again, they're looking at a more obese category. And the other criteria you can clearly see. Again, so these were, again, a lot of them were in a secondary prevention cohort. So you had patients with baseline CAD, cerebrovascular disease, heart failure, PAD, right? Again, you can see more of coronary artery disease. So you're looking at more patients with CADs rather than more patients with heart failures. Some of them already had CKD as well. Then one thing which was very important, which makes this as a modern trial, if you look at the earlier GLP trials, most of them did not have patients on SGLT2 because they started at an era where SGLT2 probably was not dominating. It is very difficult to now do a clinical trial, and it's not ethical to do a clinical trial for a patient who is at high risk but an SGLT2 is not prescribed, which makes SOUL trial very unique because we had 26% of patients on SGLT2 right at the bat, which is very important. So now it makes a very interesting point to see whether this trial really lives beyond its benefit, beyond an SGLT2, and then it did. So if you see the clinical trial and you see the clinical results, the 3-point maze, you had again statistical significance and a very good number needed to treat, NNT of 50, right? So you were actually reducing events. Mainly, the event was driven by non-fatal MI. Okay, so yet main driver In fact, the only statistical significant driver is non-fatal MI, right? So of course you had 3-point MACE reduction here. You had CV death, overall CV death, which is, though it is showing benefit, it is not showing statistical significance. You just cross this line, it is not statistically significant. The non-fatal MI is the one which is showing the maximum benefit. The non-fatal stroke, again, showing benefit, but not showing statistical significance. Now, let me tell you just my theory here. If you probably follow these patients for a longer period of time, all of these things will start shifting more towards the left, right? Everything will start shifting, because the problem here is that a patient selection group, and then you're looking at a timeline, which is a limited timeline. So if you follow this patient for one more decade, the stroke reduction will also be statistically significant. And if you follow for another decade, the overall cardiovascular risk reduction will also be statistically significant, right? So the point is, you are showing early signs, but you're not showing statistical significance in everything, but you will if you follow these patients for a longer time, right? That's the whole point. Again, you had a lot of patients with from Asia as well, and even in those, you had benefits in the Asian cohort also, which was very similar to what you see in the Western cohort. So again, a lot of criticism comes that, it is not, these trials are not very inclusive. They don't include Asians, they don't include females, which may be true to an extent, because, they are all commercial, clinical trials. But this, at least, from a less criticism point of view, I'd say that these did include Asians, and that benefit was seen in Asians also, right? So the MACE reduction was seen in Asians also. You had, of course, the other things. You had, you can see here the 5-point major kidney outcomes. Again, you had benefit, but you did not show statistical significance again. And remember, there are a lot of patients already on SGLT2. Again, the interesting question was whether the patient benefited. If patients on SGLT2, did they benefit or not? Answer is actually yes, right? So again, with or without SGLT2 use, there was benefit. Having said that, the statistical significance is only when you have no SGLT2 use. There is benefit with SGLT2 use at baseline, but it's not statistically significant. So just keep this in mind. Again, like I'm saying, it's a matter of time. If you follow these cohorts for a longer time, you'll find independent benefits beyond SGLT2 use also, right? So that's the whole point, okay? So the point as far as the summary of the SOUL trial is concerned, SOUL trial is now an established CV safety trial, CV benefit trial for oral semaglutide. Oral semaglutide is available in India, and currently it has the largest market share for GLP-1RAs. It's the only oral GLP-1RA currently available in the market, and the only one which is going to be available for the for the future, right? Also, because there are no other drugs currently of this segment in the market which is likely to come to India. Having said all of these, it's an excellent anti-diabetic drug. It hits the right problems which are, which we discuss about, but also now we have a CV benefit trial which shows very good cardiac risk reduction, especially in terms of, I'll just summarize, in terms of the non-fatal MI, which is again something which, which a lot of, in fact, I will probably say non-fatal MI is the disease you need to treat, because these patients are going to come back to you, right? I mean, and thank you for it, and thank the cardiologist also for it. But the point is, I'll just summarize in 2 lines. A, we are treating the wrong disease. We need to now evolve at a more, some of a one step back and look at adiposity as a disease rather than diabetes itself as a disease. And secondly, GLP-1RA has a very significant role in today's diabetes management, barring the cost, of course, that's the only challenge, right? And now you have almost large number and most of the GLP-1RAs showing cardiovascular benefit rather than just cardiovascular safety, including the only oral one available in India, that is oral semaglutide. Thank you for the patient listening.